Hello, everyone, and welcome to the second in our series of Finance and Operations webinars. I am Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health. And today's webinar is a systems approach, maintaining a high-functioning revenue cycle department. Next slide, please, Carrie. Before we get started, I'm going to go over a few logistics. Oh, let's see. Is there one slide before that? There we go. Thank you. The audio has been muted and the video is turned off for all attendees. Please select the ellipses on the right of your screen to populate the chat feature. And please use the chat feature to ask your questions. You can ask them as we go along, and we'll make sure that they're asked of the presenters. We are going to have a Q&A section rather at the end of the webinar. So you can either ask your questions again in the chat, or you can raise your hand by clicking the hand at the bottom of the screen, and we'll unmute you so you can ask your question live. And the presentation slides and recording will be posted shortly after the session on our website at the link on the slide, and I'll put the link in the chat in a moment as well. So this is the second in a series of 10 webinars that we're hosting focused on finance and operations. You'll see the next 8 webinars listed on this slide. You can also find more information on the ORH website with the link that I'm going to add to the chat in just a moment here. Each of those events needs to be registered for individually. So you can pick and choose, and you can sign up for all of them if you like. And with that, I am pleased to introduce our speaker. With us today is Carrie Bova from Wintergreen. Carrie has over 15 years of experience managing revenue cycle operations. She's an expert in optimizing revenue cycle operations and improving cash flow in rural health organizations. She has a proven record of accomplishment of increasing revenue cycle efficiencies, reducing expenses, establishing compliance, and developing growth strategies in a constantly evolving industry. Prior to joining Wintergreen, Carrie worked for multiple rural organizations. She was instrumental in successfully turning one rural hospital that she worked at for over 10 years into a critical access hospital top 100 organization. So welcome, Carrie. We really appreciate you being here to share your expertise, and I will hand it over to you.
Wonderful. Thank you, Sarah, for that lovely introduction. Today, we're really going to get into a basic overview of the processes and optimizations maybe needed to maintain a high-functioning revenue cycle. I always say that maybe too, because I know everyone within revenue cycle that has a passion for it always feels that they are doing their best, and this intent is just to kind of guide you along the way, give you some tips, tools, and resources to utilize as you develop your revenue cycle for optimal performance. And we've identified throughout the last few years, specifically as we recover from COVID, that organizations are facing a new healthcare landscape post-pandemic. As we near the end of that, and traditional methods that have been previously utilized to manage and maybe improve revenue cycle performance have become a little antiquated. And these practices still offer value, but they often fall short at optimizing collaborative revenue cycle functions. Recognition in rural health facilities that we must react quickly to survive financially is increasingly evident, and we have to kind of build upon the old strategies and implement new strategies to achieve optimal performance. So today's agenda is just going to go over some key elements to help us get there or to improve on what we're already doing. We're going to talk a little bit about understanding the components within the revenue cycle, and we're going to talk about analyzing and identifying some opportunities, establishing some revenue cycle shared responsibility and collaboration with clinical and quality teams, revenue integrity and reimbursement strategies, denials management, and then how we use all of that to leverage data analytics and benchmarking. So understanding the revenue. So this is a very large slide with a brief overview, and there are a lot of different functions, but typically the revenue cycle functions come down to 5 core elements that are included in all of these, and they are basically the pre-claim administrative functions, the front-end functions, the back-end functions, the transactional in between, and basically then using the data and analytics. So these sometimes are lumped into multiple departments within, or there's just a streamlined. We're going to talk a little bit about the functions. So I really wanted to spend some time on the administrative functions that we need to take a look at pre-claim. And those are everything from contract negotiations to provider enrollment and credentialing, your CDM, your pricing and fees for the organization, and all of those electronic data interchange processes. The pre-claim section is very important, and it can really allow for a optimal performance at every other level. So then we move into front-end transactions. The front-end section of the healthcare revenue cycle really begins with the patient scheduling, the appointment, the request for service. And it continues throughout the patient encounter until the conclusion of the visit. But it includes everything from before they get there. It includes patient scheduling, patient financial counseling, insurance eligibility, and most importantly, again, kind of a new, is coordination and identification of benefits and benefit eligibility. And we'll talk a little bit more about that in another slide. But pre-service collection, point of service collection, and charge capture, all of that financial clearance information. Then we move into the transactional pieces, which really identify, the section of the healthcare revenue cycle from charge entry to payment reconciliation. It includes your cash application, EFT processing, claim scrubbing, submission. It is the largest and most critical element within the revenue cycle, and a mistake in the transactional data set really, or a lack of internal control, can have serious implications for the overall financial health of your organization. It results in denied or delayed claim payment, and it really has a strong regulatory compliance. The back end of the revenue cycle includes your status checks, your claim appeals, your denial review, patient statements, collections, and this is where revenue is preserved and captured beyond the transactional section. And then really important is the data analytics and benchmarking of an organization. A healthy revenue cycle is efficient. It helps to streamline revenue collection while promoting that regulatory compliance, and it minimizes cost and expense to your organization. It also allows for you to identify pitfalls, gaps, and areas where you can really streamline and improve. So as we think of those functions, we have to identify ways to analyze and identify some of those opportunities that exist, and each organization is different. An analysis has to be performed to identify where you're strong, where you're weak, what your opportunities are, and what your threats are that are associated with the current revenue cycle operation. It should really involve staff beyond revenue cycle, and it's an opportunity to really identify some shared responsibility mapping. And for an example, you can use a SWOT analysis or another methodology that would assist you in identifying priorities on an individual basis, because we all know in rural healthcare, we're not cookie cutter. Every organization is different. Every task is assigned differently. So establishing those workflow priorities, the distribution of tasks, it's first it's the first step in both identifying the pitfalls, but also optimizing your processes and reducing lift. And we all know in today's market, staffing is a huge, huge challenge. So key areas that you should focus on during your initial analysis is really start identifying short and long-term goals and then defining responsibility, okay? Don't ever set yourself up for failure. Don't identify 100 things you need to improve and then give yourself a 6-month deadline. Really focusing on analyzing and saying, what can we do in 30 days? What can we do in 60 days, 90, 180, et cetera? And so really identifying those short and long-term goals and then define the responsibility. You should really ensure that your analysis includes contracting analysis. Immediately identify if there are payers who offer incentive contracts and request those. You'll see that many payers, such as Medicare Advantage or Medicaid HMO plans, will offer a per member payment for meeting preventative service and value-based care opportunities. So those are really important to get involved. And throughout the presentation, I really want everyone to keep in mind that a lot of these tasks seem daunting, but you'll see the overlap of the tasks and then the benefit of such. And then identify services in which your adjustment is more than what was paid. If your charges and payments result in an adjustment that is greater than if your payment is resulting in an adjustment that is greater than what you were paid, maybe your charges are too high. Maybe your contract is costing you money. Most payers are required to renegotiate terms if they are identified at the organization level if there's negative financial impact. So never feel challenged or be afraid to challenge that term within your payer contracts because you have a financial viability option, and it is very important to say, well, wait a minute, this is costing us more to serve your membership. We need to renegotiate now, not 3 years from now, not at the end of the term. And you do have those clauses. They're in most master service agreements, so I recommend you really take a look at that contract and see what you can do. And then really we have to identify, especially in rural hospitals and organizations, we're seeing those inflationary expenses from everything to supplies to our labor costs, and they have to be identified and considered in our contract management to make sure that our contracts are working both for us but also for our patients. The costs associated with service delivery, salary, non-salary expenses are often poorly managed, and they're often retrospective reviews instead of looking at that and having a proactive approach. So those are things to consider. Again, as you're contracting, you should consider anything that's coming via paper. Checks, remittances, those EDI transactions are the new norm. They're expanding. If you're following any CMS regulatory guidance, I just participated in a comment period where we may, in fact, have to attach physician orders and documentations through electronic transactions. So we really need to start eliminating that paper and have everything electronic. And the benefit of that is you'll see a significant impact on cash flow. It really starts to increase that days to pay, decrease the days to pay, and you start to see that cash flow coming in quicker. Roles and responsibilities. So I think it's very important to identify who's doing what, the tasks, and then of those tasks, seeing what could be automated or could be expanded to avoid additional labor lift. Often two roles are doing very similar work or the process is manual and outdated. So looking for opportunity for automation to re-center your staff where it needs to be and use the subject matter expertise and your human element where it's the most important, and that is getting the revenue through the door. Schedule resource utilization. Are we making the most in our organizations of the time that it has? So often I've seen provider preference drives appointments per day, appointments per hour, and it drives lower than standard volumes. So really, and again, this will fall into some of those collaborative teams, but really finding a way to make optimal use of those scheduled hours in the staff is an extremely important revenue growth initiative. And I'll use an example. I had a practice that I assisted, and one of the opportunities was that the revenue cycle department sat with the clinical department of the clinic and really started templating a schedule. I only want to see one well woman visit before lunch, one well woman visit after lunch, and really talking with the providers to identify their preferences, but then put that in a feasible model to increase volume, increase access to care, mitigate no-shows. You know, what can we do if we have a no-show? What do we do with that time? And then some block scheduling for same-day acute appointments. So really take a look at that schedule resource utilization and set benchmarks and collaborative team efforts to improve what you're doing. And then really use telehealth opportunities. Chronic care management, principal care management. There are many organizations that are not familiar with principal care management. So really using different care management opportunities to make that phone call if there's a no-show. Have that provider do a TCM visit during that time frame. Ask if overbooking is allowed if you have a consistent no-show problem. There's just a lot of opportunities there. Expense reduction or reassignment, and this is very important and critical. Identifying opportunities to eliminate duplication of software or people doing the same tasks or similar tasks, and then really defining if the expense for that can be a cost neutral transition into something that could be revenue generating. And I really, really want to push the care management. You know, if you're not doing chronic care management, if you're not doing principal care management, it's really an opportunity. And there are times that you are able to free up enough cash just by identifying that duplication or software expense that can be reinvested to really create a quality care metric for your patient and really improve both the patient quality care, the overall marketing of your services, and then really transitioning to value-based care. So in your contract analysis, you know, they contain fee schedules and reimbursement requirements. Again, the conditions the payer must meet for timely reimbursement. It's key to ensuring that your payers reimburse the correct amount each time a claim is submitted. In a lot of instances, staff assigned to negotiating and reviewing payer contracts are not always familiar with the reimbursement methodologies and the designation privileges that could be leaving money on the table. Again, there's a lot of specificity in our new contracts, and we're beginning to see specific revenue codes, increasingly difficult coverage guidelines, and medical policies that are constantly evolving. I know many of us lived through that with COVID. So by performing an immediate review of the existing structure, you can help to improve net patient service revenue. And some of the key revenue cycle assessment discoveries, it's really failure to identify the afforded principles based upon designation. So things like critical access hospitals are not subject to the 1 in 3 payment, 3-day payment provisions. You know, you get paid separately for outpatient and inpatient. You shouldn't be, you know, if the patient is admitted through the ER, those should be two, and then they should be 2 separate claims. So you should be getting payment on those. Failure to amend contracts with language that's non-specific. One of the key things that I've identified is we negotiated a percent of charge that was, you know, 40%, but it did not evolve with your fiscal intermediary rate letter. So really making sure we're taking care of that and paying close attention. And then there's a real identification of maintaining the demographics in your provider services with patients. Make sure that if you're adding services, you're reevaluating the contracts to make sure those services are going to be paid. There is a lot of contracts that are either missing appropriate pharmacy and supply reimbursement, or they're not appropriately identified. So really taking a look at those. And then the provider-based department and the technical components, making sure that if your clinics and things are provider-based, are you billing everything on a 1500, or are they actually looking at those UBs and paying you the appropriate way? So that is an extremely important, and the only other thing I would recommend is, as you're reviewing those, is to build a contract matrix that basically outlines the services and the payments that are supposed to be expected, and utilizing that as an education tool for your patient billing departments. So again, optimizing those revenue cycle tasks and functions, really take a look at where everything falls back to this, and then no matter how you divide them in your organization, just make sure that those core task elements are incorporated and monitored. So that contract negotiation, how frequently are you reviewing them? Are the right people at the table or reviewing the negotiations? Same with CDM and pricing. Are you passing on too much to your patients? Are you making a marketable strategy for retention? So it's really important to just, no matter how it is identified, make sure the core elements are addressed and that you have internal controls for those. And we talked a lot about identifying duplicity and any redundancy. So I really want you to these are some opportunities to take advantage of. Specific with software vendors, a lot of times they will do an optimization of your software assessment and report, and they will identify that free of charge, right? So eliminate the lift. Don't worry about those staffing challenges. See if the vendors can do that for you. Again, we're talking about some key assessment and discoveries. There's failed implementations or lack of feature utilization, adding manual reporting lists, as opposed to reevaluating or supporting the software with upgrades. I've been in a lot of places who don't routinely update interqual criteria. So something may later deny for medical necessity, but it is because interqual and the priority packs and updates weren't implemented. Duplication of services. I mean, eligibility platforms are often purchased because there's a problem on the front end, but sometimes the clearinghouse also has an eligibility. So identifying where you're paying for maybe duplicate services and try to reduce the expenses. Different charges, you know, same organization, different EMR, different charges due to not constantly monitoring that, any changes, any evolving services that you're getting, or reviews that are causing pricing changes. And just identify for similar reporting across multiple organizational roles that could be streamlined. So maybe one person is reporting very similar data and you're just looking for one more element. Maybe that is something that you can eliminate a manual labor lift and add on or sharing the responsibility, which brings us to shared responsibilities. Clinical and financial collaboration first started revenue cycle staff was really standalone for quite a long time. And then we identified that, wait a minute, maybe we're working in silos, maybe better integrated, teams and collaborative efforts can help us achieve. So successful leaders are looking for opportunities to collaborate internally and externally to learn and grow and have an increasing impact on revenue functions. And I have identified very, very positive outcomes by really starting to build teams that have both a clinical and a financial collaboration. Routine meetings with clinicians, help them understand. We don't active clinicians, but maybe they don't know what we're missing. And it could be as simple as you didn't document enough time for smoking cessation, or, hey, if you would have just included this, you could have increased the level. So just recognizing more procedure through better documentation and providers really being a stakeholder and understanding the billing that they are and the services that they're providing. And often we can learn more about what the providers are actually doing in the office that can enhance charge capture and cause additional or add-on procedures just by sitting down again and having a conversation. This, again, is talking about that improved resource utilization. And when I say that, this is not just the schedule, but it is people, it is tasks, it's everything that we have within our organization, especially with staffing challenges, to see if there is a means to balance workloads and task distribution that creates a healthier collaboration model, a healthier communication model, and then a healthier financial bottom line. And you will find, like I said, a lot of these things will become overlapping and they will just seem to flow. And it takes a little bit to get there, but as they overlap, you'll say, oh, this flow is so much better. So really evaluate your revenue integrity. And I know revenue integrity often has similar but different meanings in the industry. What I'm talking about is ensuring that all of your charges for service and supply are recognized, that your billed service revenue is returned, it's been billed in a compliant manner, and you are mitigating and eliminating any risk of future recovery. Charges and coding is appropriate, and it truly reflects all of the services being performed. So I recommend trying to get to charge reconciliation at a department level and making departments accountable. Establish routine and coding, billing and coding audits, either internally or externally, but they're very important because they identify trends and then they identify education to the end user. And then really moving to that service line contribution and accountability analysis. As you're evaluating the integrity, what are the gaps? Where are you losing money? What are we missing? Oftentimes, we're not charging for supplies in the OR because we have outdated preference cards. There's just a whole lot of departmental and financial collaboration that goes into revenue integrity. And the sooner we can get a handle on billing and coding and charging for everything appropriately, the sooner we can reap those benefits of reimbursement. So a way to do that is really focusing, and again, this is, trying to get you the immediate action. Establish a charge reconciliation process. Lag days, accountability at the department level, maintaining and reviewing with clinical collaboration charge master, and then establish routine monitoring and responsibility of a charge lag report. Every day that we don't get a claim out the door, so that what I mean by charge lag is if it takes 5 to 15 days to apply charges to an account, it's too long. You're putting revenue at risk. And then really educating departments, providers, key stakeholders on missed charges that are identified, opportunities, and a gap analysis of how can we prevent this in the future. Establishing reimbursement strategies. This is my absolute favorite slide. Reimbursement strategy should be past, present, and future. Immediately evaluate your claims for payment variance, denial management, accurate charge capture, coding, and billing. And the way that you would do that is you would pull remittance data and identify trending. What's wrong? What didn't pay according to contract? What is a frequent denial? And then really walking it back to see how you can preserve it right now, work with payers to get anything, resolved, and then moving forward, how you're not going to continue to have that. The present, invest in those front-end processes and management to grow existing revenue from your current patient base. I really am, this is incredible to me, but I see it and I've seen it. I implore you all, just a little tip. Take a patient, go out to Medicare, however, if it's NGS or First Coast or whatever your organizations use, and really look at the preventative service eligibility. Oftentimes you will find that that patient is eligible for ancillary services that you can communicate to the provider right now, and they can generate anywhere between $500 and $3,500 per patient, and you're moving towards a value-based care model. And then a future. By implementing and monitoring workflows focused on preventative care, principal care management, chronic care management, future revenues can be achieved in the form of incentives and reduction and release from payment penalties. So just some tips here: evaluate contract variances, work through underpayments and denials from a project scope, not an individual scope. You don't want your patient account rep on the phone one claim at a time. Look for payers. A lot of them have them out on their website, their claims project spreadsheets. Identify those trends, get them on the spreadsheet, establish a meeting with that provider rep. Evaluate billed claims for expired CPTs and rebuild accordingly. A lot of times we're seeing in that CDM, if the CDM isn't managed, there's a lot of expired codes that are being denied. Let's make sure that CDM is up to date. You're identifying for any expired CPTs, and you're really getting those claims back out the door. We did talk about bundling or inclusive denials. Is there a modifier application? Is there something that is a separately identifiable procedure? Diagnosis hierarchy and unspecified codes, they lead to denials, and they lead frequently to a significant revenue gap. So please, taking a look at some of those for the appropriate hierarchy. You know, is the patient here? A lot of times you could have those just pulling onto claim forms alphabetically. I've seen that. Let's check those, make sure they're pulling priority instead of alphabetically. So that is important. And then routinely on Monday, every Monday, run a billed and unpaid report for timely review and turnaround of revenue, really getting everyone involved. I know a lot of people say, well, we don't have the time. We don't have an option not to have the time. So really incorporating that billed and unpaid, those denial reviews, timely and effective monitoring and internal controls can really help turn that revenue around and impact cash flow. It also eliminates that loss. The present, establish those front-end processes that identify quality gaps in preventative services and ensure that it's communicated to your providers. It can allow for immediate generation of ancillary revenues, and it improves that quality and value-based care provision. There are no out-of-pocket for most preventative services. Explaining this during the financial counseling process can really help promote that patient buy-in. Do not limit your, preventative services to traditional Medicare. Implement that strategy across all payers. And again, many give you a per member, per month payment. So really focus on that. And then focus on point of service or pre-service collections. When you're scheduling that appointment, are you identifying to your patient, this is your out-of-pocket? Now that also helps with compliance with the No Surprises Act. So really working through, trying to collect that, then you're not paying the statement cost. It isn't sitting out there in lag. Every day that you don't have money, you're going beyond, you're incurring additional expenses. Identify additional revenue opportunities across the organization and pursue the revenue capture of those. So, for example, a patient comes in and Dr. So-and-so always bills a 99213, but he also spends an hour with the patient. What else is he doing in that time frame that could be a potential chargeable event? And again, this is that overlap of the collaborative care and the shared responsibility mapping. And then that reimbursement strategy for the future. Pursue the preventative service, but make strategic advances toward educating staff on quality measures as a revenue growth opportunity. Consider it a grow as you know approach. As you start those collaborative models, you'll start identifying maybe they're doing things that could generate additional revenue. Maybe there is an expansion, or they're, talking about more than just a, maybe it's not just a 99213. Maybe they're talking about more than they're documenting. Educating and strategically communicating with patients will improve performance with minimal out-of-pocket cost, and it improves your patient care management and quality. It reduces the cost to collect expense that you are beginning to build that rapport and a marketable consumerism strategy for your patients. We see this all the time, consumerism in healthcare. It is the new trend. Patients are shopping where they want to go. Make sure that you are, and I don't mean to laugh, you're either Tiffany's or Walmart, whatever they want, but you want to have the prices of Walmart while delivering the quality of Tiffany's. And then that contract analysis, amendment, and addendum. It's also going to create those incentive-based contracts. It's going to create a more profitable future state. Denials management, we spoke of this. We are fighting for financial sustainability due to increased operational costs associated with wages, inflation, everything. We're still seeing pandemic-driven lagging of patient volume in some cases, and then continually changed reimbursement policies. 17% increase in claim denials in 2021 alone. And another startling statistic from the poll was that only 40% of denials were being resubmitted by a practice or an organization. That is no longer optional. It is absolutely critical for success, for financial sustainability. So what's your strategy? Establish a team. Identify the resources to leverage expertise and input. Organize your processes. Again, identifying those trends and root causes, walking it back. It's survival mode. How do we fix it? No blame. Let's just work together. And then implement those solutions. Identify clear and concise policies and protocols to ensure recovery of those current denials and prevention of future denials. And then analyze, act, and celebrate. I can't tell you enough, really focusing on those end users and allowing them to be successful. I myself still have the first huge denial, win on appeal I ever had. I still have the letter that was returned. It is a big deal, and really celebrating them will buy into them wanting to perform more. Really investing in your workforce and celebrating them and letting them know what they do for the organization is a big deal, and it helps with staff retention, which is also an expense reduction. Data analytics and benchmarks. As you walk through your analysis, you'll find that you're monitoring and improving through a more sustainable and proactive workflow that does leverage data analytics. The analytics will allow for the organization to choose what to measure and when. Choosing the right key performance indicators and building to a more comprehensive KPI dashboard will allow you to evolve and continually optimize. It will drive revenue improvement throughout your organization. But again, don't focus on the wrong standard analytics. Focus on the right ones. Creating optimal workflows, patient satisfaction, quality care, and resolving revenue gaps can be achieved as your organization focuses on specific and actionable goals that apply to your organization. Rural health is not cookie cutter. We cannot all be working together in the same, manner. Some of us have different opportunities than others. So really taking a look at that. And then leveraging those data analytics to establish the benchmarks, identifying the action tasks with 30, 60, 90 days, et cetera, can prioritize. but then you're also building the reports and the standard operating protocols that really, really, really can help overall. So here's an example. 30 days, incorporate a daily review within 30 days of scheduled next day preventative services. So basically, every patient, see what you can do, and maybe start with traditional Medicare, but get to all of your payers. Hold collaborative team meetings to ensure that the intent, objective, and communication to the providers is documented and understood. So if you go out to check a Medicare patient's eligibility, it will tell you the eligibility dates for the preventative services. Really start looking at that and saying, okay, we're going to put the eligibility and all the eligible services for preventative care on the front of the patient, screen and EMR, or we'll put a billing alert in so the provider orders the ancillary, and then communicating what that is to the providers. Within 60 days, evaluate those generated patient orders for the ancillary service based on your new process, and identify a way to monitor generated revenue. You are building your data analytics. In 90 days, you should be ready to formally document the process for staff education, onboarding, and continuing education. Now you have a process. Now if turnover is high, you can go back to that standard operating procedure and share that with new staff members. In 180 days, evaluate how that process has improved your patient quality care, maybe via Press Ganey, maybe via, just service analysis, anything you want to do. And then use for performance improvement reporting. Again, everything is overlapping. So you're minimizing lift and manual workflows, but you're constantly evolving your organization beyond the revenue cycle, really that quality finance collaboration. And then in 360 days, reevaluate your clinic, service line contribution, RVUs, whatever, but to show continual progress and financial viability of that service line. Just quickly, before we go into, some of the questions, et cetera, I really want to talk about identifying key performance indicators that are where you want them to be. Multiple assessments have led me to one conclusion. There is too much focus and not enough internal control can lead to incorrect priorities and put you at risk for compliance, audit, and recovery. And while data analytics are useful, a lot of times they put too much pressure on revenue cycle leaders, and that can lead to write-off. And a lot of times we're writing things off because that benchmark of days in AR is so important, but every dollar counts. And focus on a gap analysis and a process improvement that will get you more per billed dollar as a more important measure than days in AR. Really, we'll get to days in AR, we can get there. But right now we want to make sure we're getting every dollar that we're entitled to. And so with that, I'm very impressed that I stayed on the timeline for questions. We will open it up for some questions.
Thank you so much, Carrie. Really, really great presentation. As you mentioned, we're moving into the Q&A portion of our session. So you can put your questions in the Q&A box, or you can raise your hand, which is the little hand button on the bottom right of your screen. And we will make sure that those questions get answered. In the meantime, I have a couple of questions that have come in, Carrie.
Okay.
So the first one is provider preference drives so much of the inconsistency in our schedules, which impacts our revenue. Are you seeing changes in the traditional production-based incentives in the work you do across the nation?
Yes. Yes. So essentially, really, but again, I go back to those collaborative models. Providers are set in their ways. They're also very difficult in rural healthcare settings, it's a lot of times we let providers do whatever they want because we're really concerned about retaining that provider, but meeting them halfway, it has been very successful. And we have seen in some, I personally have seen in some where you're getting a 10% increase per day just by sitting down and templating what they prefer with the providers and really talking to them about organization of schedule. Opening up block scheduled hours for walk-in appointments helps to prevent a delay. And then really using no-show and telehealth opportunities to mitigate and improve schedule utilization. So for example, Susie Smith no-shows frequently. She frequently is scheduled for 30 minutes. Well, let's see what we can do in that 30 minutes. How many of the patients have a TCM? You know, how many providers need to make a phone call for a transitional care management for an admitted patient within the last 7 days? 7 days is optimal, right? It's a higher reimbursement. How many people can we now, and not forever, but until May, do a virtual check-in? Are there things that we can do with some of those patients? If we can't get Susie Smith in the office, can we get her on the phone? Can we do a virtual check-in? Can we do a telehealth visit? Can we talk to her about chronic care management and use some of that time for some of those? And what you will see is it really, the providers buy in quickly because they are improving RVUs, et cetera, by just working with the finance team to collaborate and make that model.
Great, thank you very much. Going back to the issue of contracts, how often should you review your contracts?
So initially, I would recommend, if you haven't done it in a while, I recommend that you review your contracts at least once annually because there are so many CMS changes. I mean, CMS changes occur probably up to 4 times a year just with codes, right? If not more. So really once a year, taking a look at those contracts, making sure that they mirror your organization's current state. So maybe you've added cardiopulmonary rehab, or maybe did your contract evolve with that service line addition? So I would recommend at least annually, if not right now, maybe, if you're a constantly evolving service line, maybe biannually, but definitely annually.
Right. And kind of along the same lines, then going into renegotiating contracts, what are some tips that you have for successful renegotiation?
Ooh, I have a lot of them, but I think the most important is really make sure you have dispute resolution. So really don't limit yourself. Make sure that you have a comprehensive knowledge, or the people that are negotiating have a comprehensive knowledge of reimbursement strategies. Make sure that you're very comfortable and aware of your designations. Critical access hospitals, rural health centers, what is allowed within the rural health center, what's allowed to be billed under the provider if it's a subpart and it's a provider-based rural health center. And then I think a lot of times there's a feeling of disadvantage of that, but really optimize like escalator clauses. So as you know, inflation is going, say, okay, year 1, year 2, maybe we have a certain percentage increase. Year 3, if they're 3-year terms. So there's a lot of different things, but my most important is really identifying, escalator clauses, dispute resolution processes, and then make sure that your contracts are specific enough that they meet your need, but not so specific that, and I saw this a lot with COVID, where you may have a managed care contract that said, yeah, we'll pay your car rate, but as your cost report, as your reimbursement rates, like percentage of charge ratios increased, they didn't increase with your managed care contracts. The other really important thing is, if you do have that, identifying par terms and then terms for them to have to get your rates uploaded. So 60 days upon the notification from CMS, you will increase our swing bed per diem rate per the fiscal intermediary rate letter. Really making sure that those types of things are defined to really mitigate loss. And those are just some suggestions, but those are the most important. So dispute clauses, escalation clauses, and then terms for adjusted rates.
Awesome. Thank you. Great strategies there. I am not seeing any more hands raised or questions in the chat, but we'll give it just a moment for folks to
And we
jump
see that
in.
too a lot. So never hesitate to just shoot an email either. We're happy to answer questions. Sometimes you take it all in and you think tomorrow, oh, I wonder. So always available for a quick call, conversation, or an email to guide very specifically to your organization.
Awesome. Thank you for that. And I don't see any additional questions coming in. So if we can scoot over to the next slide, that would be great. And the next one. There we go. Before we leave today, I just wanted to provide some announcements from the Office of Rural Health. We have our Forum on Aging in Rural Oregon coming up May 15th through the 17th at the Seaside Convention Center. Registration opened in February, and I believe I put the link on the slide, which you'll receive via email along with a recording of this session by tomorrow. Um, and we're co-locating our CA quality workshop in the same location. So the Seaside Convention Center, I have a typo in there. That's May 15th through the 17th as well. May 15th starts at the very end of the day. And registration is opening up this month for that. Reminder that our unmet healthcare needs report is now available and provides you with some comparison data across the state on primary care service areas and needs that are identified in rural areas. And then finally, our next webinar, PIEC 101, Transitioning to a Performance Improvement Executive Committee, will be held on March 30th at noon. And the webpage that I put in a couple of times in the chat has the registration information for that, and we'll also be sending emails out to promote that webinar. A survey will pop up after you exit this webinar, so please take a moment to complete it, as this will help us continue to bring programs just like this one. And really, thank you again, Carrie. Much appreciate the information that you shared today. And we're looking forward to our next webinar with Wintergreen on the 30th.
Thank you, Sarah. I appreciate it. And thank you, everyone, for your attendance today. Again, never hesitate to reach out.
Have a great day, everyone.